So, hello, good morning, everyone, and good afternoon to those in Nepal. I'm Dr. Kumar Yadav, ITR 18 from the third batch, and today I'll be presenting on temporomandibular or TMJ joint dislocation. So, we'll be discussing about the anatomy, incidence, pathophysiology, and everything of the TMJ dislocation today. Uh, TMJ dislocation is a fairly common presentation in the ED. According to the data, 1 in 10 people in the UK suffer from some sort of temporomandibular joint disorder in their lifetime. So, talking about the anatomy of the TMJ joint, TMJ or the joint is a synovial, condylar, and hinge type of joint. It consists of the articulation of the temporal and mandibular bones. There is the articulation between the condyle of the mandible and the mandibular fossa of the temporal bone. So TMJ joint has many life-sustaining functions. So those functions are carried on by certain movements, and the TMJ joint has both simple and complex movements. Simple movements like in phonation, in gesticulation, in swallowing and breathing, and in complex movements like incision and chewing. So those movements are achieved basically categorized into two types. One is the rotational movement in the sagittal plane and a translation movement in its own axis. So this is the figure representing the TMJ joint. Here you can see the condyle of the mandible, and this is the mandibular fossa of the temporal bone. This is the articular eminence, and this is the coronary process of the mandible. So let's talk about the incidence. According to the data published in Emergency Medicine Nursing Journal, the prevalence of TMJ instability in the general population is about 25 to 50%, and it has the highest incidence in middle-aged women. TMJ dislocation is thought, the presentation of TMJ dislocation in ED is thought to be 5.3 per 100,000 patients. Now coming to the pathophysiology of the TMJ joint dislocation. TMJ dislocation occurs when the condyle travels anteriorly along the eminence, that is the articular eminence, and becomes locked in the anterior superior aspect of the eminence. And this leads to the spasm of masseter, internal pterygoid, and temporalis muscle, the muscles of mastication, which leads to attempting to close the mandible. This results in trismus, and the condyle cannot return to the temporal fossa. TMJ dislocation can occur either anteriorly, superiorly, or posteriorly. Anterior dislocation is the most common, superior is uncommon, and posterior is rare. TMJ dislocation may be either unilateral or bilateral. It may be acute, chronic, or chronic recurrent. It can be further classified into three types. So this is basically anterior TMJ dislocation classification, and this is based on the clinical and radiological evidence. Type 1, when the head of the condyle is directly below the tip of the articular eminence. Type 2 is when the head of the condyle is in front of the tip of the eminence. And type 3 is when the head of the condyle is high up in front of the base of the eminence. So how may a patient with TMJ dislocation present to you or in the ED? So TMJ dislocation presents with mandibular pain and inability to close the mouth. This may either result from trauma, but more often it occurs from extreme opening of the mandibles, like in yawning, or when there is history of prolonged jaw opening, like in dental procedures. The dislocation may also occur because of excessive contraction of muscles of mastication. That may be either due to dystonic reactions, seizures, or tetanus. And TMJ dislocation may also occur during general anesthesia and intubation. So recurrent dislocations are common, and patient may present knowing they have an anterior dislocation. Verbalization of their complaint is often difficult because their mouth is stuck open and they cannot gesticulate properly. Uh, on physical examination, jaw dislocations are usually readily apparent. The jaw will not be able to close, and the depression can be felt and seen in the preauricular area. There may be the appearance of an underbite as the mandible is anteriorly displaced. While you are examining, we should also look for symmetry of the joint because it may either be unilateral or bilateral. And if a traumatic mechanism is suspected, a secondary survey is warranted uh, um, to rule out any other fractures and any other injuries. This is a picture representing the TMJ dislocation. Here we can see that the condyle of the mandible has been displaced anteriorly in front of the articular eminence. So how do we diagnose TMJ dislocation? So usually TMJ dislocation is a straightforward diagnosis if it is non-traumatic, but we may have to do a radiological evaluation, that is a panoramic view of the mandible or a CT scan of the facial bone if the diagnosis is uncertain or if the mechanism of TMJ dislocation is due to trauma. Panoramic jaw radiographs are also preferred in children because of low radiation exposure. So this is a figure of panoramic jaw X-ray. Here we can see that on the right side there is TMJ dislocation. Differential diagnosis. So the diagnosis of a TMJ dislocation is pretty straightforward. However, temporomandibular joint disorders has many presenting complaints, and therefore consideration for other etiologies is also warranted. Sometimes pain can be secondary to pulpitis or odontogenic infections, headache, and otitis media, sinusitis, and trigeminal neuralgia as well. So there are certain situations in which a sub-specialty consultation is required in TMJ dislocation. Those are patients with an anterior TMJ dislocation in association with a fracture, uh, patients who fail reduction of an anterior TMJ dislocation despite multiple attempts, and patients who have had more than 2 prior TMJ dislocations, and patients with superior or posterior dislocations. Uh, so, as it is a dislocation, it's an emergency, and we need to reduce the dislocation. So we have to prepare for the reduction. During preparation, patients with TMJ dislocations are usually anxious and in pain. So the patient and for children, the caregiver should receive an explanation concerning the injury and the procedural approach. Case reports indicate that successful reduction without sedation may be accomplished using techniques such as syringe, intraoral or wrist pivot technique, and extraoral technique. If manual reduction by the traditional method is planned, sedation and muscle relaxation with benzodiazepine and pain medication, fentanyl is advised. In some instances, peripheral nerve blocks of the mesenteric and deep temporal nerves in conjunction with local infiltration of the TMJ capsule may allow reduction of TMJ dislocations that are otherwise difficult to reduce. and this may avoid the need for procedural sedation and general anesthesia. So approach to reduction, there are certain techniques by which TMJ dislocation can be reduced. The first one is the syringe technique. In this technique, the patient is asked to bite the syringe between their molars and roll the syringe forward and backward. This action is supposed to relocate the joint, displaced joint back into the place. So this is the graphical representation of the method. Another technique is traditional technique. In this technique, first the thumbs are wrapped with gauze piece, and pressure is applied over the molar areas. The jaw is pressed downward and backwards. This is the traditional technique. And the wrist pivot technique. In this technique, also the index and the fingers are protected with the gauze piece, and pressure is applied to the chin in the upward direction by the thumbs and downwards by the other two fingers, and using the pivotal action of the wrist, the jaw is pushed backwards, and this will also help in relocating the jaw. And this is the extraoral or temporomandibular joint dislocation, extraoral technique for TMJ joint dislocation. In this method, usually this is done for unilateral joint dislocation. And so in this method, pressure is applied on the non-affected joint side, so that the affected or the dislocated joint side comes back into the place. So this is the figure demonstrating the technique. And this is supine position technique for the reduction of temporomandibular joint dislocation. So disposition. After a successful reduction of TMJ dislocation, patients may need radiographic evidence to ensure adequate reduction and to exclude any avulsion fracture. If available, a panoramic jaw X-ray is preferred, and radiograph may be omitted in skeletally mature patients if the jaw feels back in place, dental occlusion is normal, and jaw movements does not produce any pain. Following the reduction, the patient should receive the following instructions. They should be told to avoid extreme opening of the jaw for 3 weeks. In some patients, placement of a padded rigid cervical coral may facilitate the instruction. They should support the lower jaw when yawning, and they should apply warm compressions to the TMJ area for 24 hours. They should maintain a soft diet for 1 week and should take NSAID for pain and swelling. And this should undergo evaluation by an oral and maxillofacial surgeon in 2 to 3 days. So some people can have recurrent TMJ dislocation. Patients with recurrent dislocation may be helped initially with the application of Barton bandage. I'm sorry, I forgot to put the picture of it, but I think most of you have seen it. After reduction, this is a sling that wraps around the top of the head and mandible and keeps the mandible in place. In addition, intermaxillary fixation with wire and elastics may be necessary, but we can't do that in ED. Mandibular dislocation that persists or recurs despite fixation often leads to frequent emergency department visits. This problem may create suspicion of malingering or drug-seeking behavior on the part of the patient, but may also indicate that the presence of an orofacial movement disorder involving the lateral pterygoid muscle on one or both sides may be present. Other therapies for recurrent dislocations include botulinum toxin into the lateral pterygoid muscles and surgery like immunectomy or immunoplasty. So these are the references for my today's presentation. I'm at the end of my presentation. Thank you.
Thank you, Shambhu, for the presentation. Any questions? Any?
I think I can make a statement. The one particular patient, the differential diagnosis is with the oculogeric crisis. In a psychiatric patient who are on these, anti-muscarinic drugs, and also when you give Maxilon, metoclopramide, or prochlorperazine, these are drugs. So that can be mistaken for dislocation. So we need to be particular about that. And the other thing is when we try to relocate it, the force is quite considerable force required. So not just like little slap on the cheek or something. So really, it needs quite a bit of force. And I think proper sedation is very important. So the important movement is a downward, push. So once you push it down, then the masseter muscle and these muscles, they automatically take the joint in the cavity. So I think the movement, the force is you need to push it down quite a bit, to be successful. And I think recurrent dislocations, you might go with the same technique or something like that, but the first time dislocation, especially as he is saying the type 3 one, so I think that might need quite a bit of sedation as well. So supine position is interesting because when you sedate people, so sitting up technique might well be a bit frowned about, because when people are sitting up, you sedate them, blood pressure might fall and they might go to faint and the fits and these sort of stuff. So I think it was a good presentation, good concise presentation. Well done.
Thanks, Mr. J. Yeah, I just wanted to add on to say that in my last TMJ dislocation reduction, I had to use diazepam because muscle relaxation was essential before anything else. Otherwise, I was not going to be able to reduce this dislocation. Yeah. And I used the traditional method as well.
Yeah, the anatomy of the joint is quite complex. Of this, it's a compound joint, is it? Because it's
Yes,
a hinge joint and the synovial joint is a compound joint, as the movement is complex as well. So, particularly its attention with the fibrocartilage in between the joint is quite a bit of, wedge set of, cartilage into the joint. There are a lot of ligaments, and I don't know how many muscles are working on the joint. Is a round about dozen or 10 to 12 muscle?
I think you have to involve the pterygoids and temporalis muscle. Yeah.
2 pterygoid, 5, 6 hide muscle, temporalis, masseter.
Temporalis masseter.
Yeah, so there's quite a few muscle which are acting on this joint. So TMJ is a quite complex joint.
This has got a capsule in it that protects.
Yeah, you're right.
Yeah.
Capsule has. There's quite a bit of complex joint. And, we've seen quite a few, I think quite a few dislocation. We don't see it daily,
Yes.
And we don't see them. I don't know. I mean, weekly. Do we see weekly? No, I doubt that we see them weekly.
No, my last reduction was when I was in Scamper. I've not seen anything in DRI. And
Yeah,
I've been here for 1.5 years.
yeah. It's not very common.
Yeah.
I mean, 3.5 per 100,000. That's acceptable. It might well be that's the range.
Mm.
But I think differential diagnosis is important. Because of this oculogeric crisis, and even as you were mentioning, infection of the ear. So any sort of masseter can be mistaken as a dislocation. So we have to be careful about differential diagnosis.
I think Shambhu, the presentation was good, concise, but I think it covered most of the things that we need to cover in it. 3.5 for 100,000 means in Doncaster in a year, we may have 6 or 7 total.
Yeah.
So that means one every alternate month. So difficult to get one.
Yeah, you're right.
I think having listened to your presentation, I have been exposed to a lady who used to dislocate her TMJ just for morphine type of thing. So she used to come, and you did touch on that one. And sometimes she was easy to push back. Sometimes it was very difficult to push back. So that lady, I think I have seen 3 or 4 times. So that counts very high. Otherwise, it's not an easy relocation. If you haven't done it, I don't think you'll be able to do it because it needs a little bit of force through your thumb. So you have to know how to do it. That is one thing. The X-ray wise, a recurrent one, I don't think needs an X-ray because we know what to do, isn't it?
Yes, sir.
Pain management, of course, is important, which you have touched. For me, the learning point was a supine way of relocating, which I've never attempted. So maybe next time, if it comes, we can try. And overall, I think probably just as a trainee factor, you could have pushed this a little bit further, bringing 1 or 2 cases, making it maybe at least half an hour long presentation. Because sometimes, if you do a 20-minute presentation in a 40-minute slot, anybody like me can say, is this Shambhu just trying to get a tick box for his slot, or was it just a smaller content? So time management is also important. During the teaching session, we really stress don't go over time, but going under time is also equally important. That's it from me. Well done.
Okay, sir. Thanks.
I think dragging it long, probably you might have spent a bit more time on the anatomy and the ligament attachment and that sort of stuff. So it would have dragged a bit longer, and differential diagnosis, but it was just dislocation, is there, so. So what's the next one now?
So we finished early, so we have like 9 to 10 and 10 to 11 session by Shara Garner.
Yeah, I've just come on a little bit early. I can do my presentation. Well, it's not presentation. You're going to do some work. I can do my bit now.